Looking at how some of our substances in the gut are regulated, we can go through some of these regulatory substances, starting with our source in the stomach. We have gastrin, which is secreted from G cells in the antrum. We have ghrelin, gastric acid from our parietal cells, intrinsic factor from parietal cells, pepsin from chief cells, bicarb from mucosal cells, and somatostatin from our GI mucosa. In the small intestine, we have gastrin from our G cells in the duodenum, cholecystokinin from our I cells in the duodenum and jejunum, secretin from our S cells in the duodenum. Glucose-dependent insulinotropic peptide is from K cells in the duodenum and jejunum, motilin and vasoactive intestinal peptide, and bicarbonate. From our pancreas, we have alpha amylase, which digests starch, lipases, which break down fat, proteases, which break down proteins such as trypsin, chymotrypsin, elastase, and carboxypeptidase. Reminder, they are secreted as a proenzyme or a zymogen. Trypsinogen, which gets converted into trypsin, will activate these proenzymes here. It'll convert trypsin or it'll convert trypsinogen to trypsin by enterokinase, which is a brush border enzyme in the small intestine, and that's a miniature positive feedback loop. Some other sourced kind of hormones or regulators of the gut include vasoactive intestinal polypeptide, which is created in our parasympathetic ganglia, in sphincters, and in the gallbladder. Nitric oxide, which is secreted by most of our endothelial cells. Somatostatin, which is produced by our D cells in the pancreatic islets. And bicarb, which is produced in lots of areas. Looking at bicarbonate and its function is to neutralize acid. It's upregulated with pancreatic and biliary secretions, and it's also upregulated with secretin when secretin is secreted. It gets trapped in mucus that covers the gastric epithelium, and it's part of what protects our gastric epithelium against the real acidity of the stomach. And this is just showing a relationship between bicarb secretion within the lumen of the pancreas and kind of within our bicarb buffering system with the capillary. Cholecystokinin is action is to increase pancreatic secretion and gallbladder contraction, as well as to relax the sphincter of Oddi to release all those contents into the small intestine. It will also help decrease gastric emptying, so kind of stop the amount of gastric contents that are moving into the small intestine. It's triggered to run with an increase in fatty acids or amino acids. It also can act on neural muscarinic pathways that then lead to pancreatic secretion. Gastric acid's action is to decrease stomach acid, and it's increased with histamine response in the body, vagus nerve stimulation, which can happen from lots of different reasons, including acetylcholine or gastrin. And it's decreased with somatostatin, GIP, prostaglandin, and secretin. Speaking of gastrin, its job is to increase gastric hydrogen ion secretions. It also can help with growth of the gastric mucosa and with motility of the gastric region, the stomach. It's increased when the stomach is distended, indicating food's present. If the stomach gets too alkalinized, if amino acids are less than peptides, so if we have larger proteins present, and with vagal stimulation via gastrin releasing peptide. It's decreased when the pH is really low as part of a negative feedback loop control. And it will also be increased with chronic PPI use, proton pump inhibitor use, or in atrophic gastritis or Zollinger-Ellison syndrome, which is a gastrinoma. Ghrelin's job is its action is to increase appetite. It is increased when we're in a fed state, and it's decreased, or fasting state, and it's decreased when we are in a fed state. There's other factors that can be increased with the Prader-Willi syndrome, and it's decreased after bypass surgery. We can see that leptin balances it out. Leptin is the balancer. Glucose-dependent insulinotropic peptide, or GIP, its action has both exo and endocrine function. Exocrine-wise, it's going to decrease gastric hydrogen ion secretions. Endocrine, it's going to increase insulin release. And it's increased by fatty acids, amino acids, and glucose. And gastric inhibitory peptide will inhibit or control this substance. Intrinsic factor is a high yield one to note because it is required for vitamin B12 uptake. It's vitamin B12 binding protein. Vitamin B12 is absorbed in the terminal ileum. It's increased with vagal stimulation, acetylcholine, gastrin secretion, or histamine, and it's decreased by all those same things that decrease our acid production, somatostatin, GIP, prostaglandin, and secretin. We can see an autoimmune destruction of parietal cells that can lead to chronic gastritis as well as a pernicious anemia due to the inability of B12 absorption. Motilin produces a migrating motor complex in the gut. It's increased when we're fasting, and motilin receptor agonists are used to stimulate intestinal peristalsis or intestinal movement. Nitric oxide, its job is to increase smooth muscle relaxation, which could include relaxation of sphincters, including the lower esophageal sphincter. When we have loss of nitric oxide secretion, that could be implicated when we have too much tone, and we can see that in conditions like achalasia. Pepsin is protein breakdown. It's increased with the vagus nerve with acetylcholine or local acid. And pepsinogen is the inactive form that's secreted first, and it's converted to pepsin in the presence of acid. Secretin is increased, or its action is to increase bicarb secretion from the pancreas, as well as bile secretion from the gallbladder, and it will decrease gastric acid secretion, so digest what's present and not let any more come through. It gets increased or upregulated with acid or acidity or fatty acids in the small intestine. And bicarb, it's important to note, neutralizes gastric acid in the duodenum, which allows our pancreatic enzymes to function. Somatostatin, its job is to decrease gastric acid and pepsinogen secretion, our pancreatic and small intestine fluid secretion, gallbladder contraction, and insulin glucagon release. It's upregulated when there's acid present. It's downregulated by vagal stimulation, and it inhibits the secretion of a variety of other hormones. Our vasoactive intestinal polypeptide, its job is to increase intestinal water and electrolyte secretion, relax intestinal smooth muscle, as well as sphincters. It's increased with distension of the gut and vagal stimulation. It's decreased when we stimulate the adrenergic nervous system. And a VIPoma is a non-alpha and non-beta cell islet pancreatic tumor, which secretes VIP versus WDAHA syndrome has water diarrhea, hypokalemia, and achlorhydria. Looking at how some of our macromolecules are digested, our lipids digestion starts in the stomach. We ingest it in our triacylglycerol form or triglyceride form, and we munch it down to fatty acid form for absorption through intestinal cells. They're prepped for digestion in the stomach through grinding and mixing action to make an emulsification. Think about like salad dressing. And once lipids move into the small intestine, the emulsification is even more enhanced thanks to bile acids, which are amphipathic molecules that come from cholesterol and are made in the liver and are secreted in the gallbladder in response to cholecystokinin. By binding bile salts to fat, we make them more soluble. Lipases, which are the pancreatic enzymes, break down triacylglycerols to free fatty acids and monoacylglycerol, which are the final products of lipid digestion, free fatty acids and monoacylglycerol. They get carried in through micelles to the plasma membrane of the intestinal epithelial cells, where they're then absorbed. And micelles are globular and formed by small lipids, where the polar heads are outward facing and the fatty tails are inward facing. Bile salts will stimulate formation of micelles as well. Fatty acids then get transported into intestinal cells by FABP, which is fatty acid binding protein, on the membranes of the intestinal cells. And once inside, they're moved to the smooth endoplasmic reticulum via fatty acid transport proteins, or FATPs. Then our triacylglycerols are resynthesized from our fatty acids and monoacylglycerol into lipids, and they are then associated with proteins, and the small amount becomes phospholipids and cholesterol, and then move into the lumen of the smooth endoplasmic reticulum. Chylomicrons are formed when they transport new formed molecules into the bloodstream and the lymph stem. Versus carbohydrate breakdown or starch breakdown must be broken down into disaccharides, then monosaccharides, glucose, fructose, galactose for absorption and use in the body. Alpha amylase can cleave one or alpha 1,4 bonds of starch, but does not cleave alpha 1,6 bonds. So this gets us to di and trisaccharides, but it doesn't completely get us all the way there. And then it's important to note that maltose and maltotriose and limit dextrin are not digestible by an alpha amylase because of alpha 1,6 bonds. So alpha glucosidase digests the rest, except for dextrin. Dextrin has to be broken down by dextrinase, which are both located on surfaces of intestinal cells. Disaccharides are easier to digest than complex carbs like sucrose, lactose. Sucrose is glucose and fructose, digested by sucrase. Lactose is glucose and galactose, digested by lactase. Both sucrase and lactase are on surfaces of the intestinal cells. Glucose and galactose are transported into our intestinal epithelial cells by secondary active transport using a sodium gradient. It's a SGLT, a sodium glucose linked transporter, and fructose moves through our GLUT5 transporter, and then transporter GLUT2 releases all three, glucose, galactose, and fructose, into the blood. And more coming soon, that's going to be kind of harken back to our biochemistry knowledge. Proteins are denatured by the acidic environment of the stomach, the pH being 1 to 2, and then our ionic and hydrogen bonds are broken down due to that low pH. Proteolytic enzyme pepsin also starts to work on proteins in the stomach, and pepsin breaks proteins into smaller fragments. A quick aside, our gastric proton pump, our potassium or our proton potassium ATPase is located on the cells lining the stomach, and it's very similar, if not just like our potassium sodium pumps that we've talked about before. And this pumps protons into the stomach in exchange for potassium with the cost of ATP breakdown, ATP hydrolysis. Okay, back to proteins. Proteins that are partially digested, carbs, and lipids move from the acidic stomach into the small intestine via the pyloric sphincter. The low pH of our stomach mixture stimulates our small intestinal cells to release secretin, which is a hormone, so it's released to the blood. Secretin promotes the release of sodium bicarb from the pancreas, neutralizing the acidity. Our polypeptide products of pepsin from the stomach will stimulate the release of cholecystokinin, again, a hormone, by intestinal cells, which is then the pancreas responds to by releasing our cascade of digestive enzymes into the intestine to continue protein digestion and start digestion of lipid and carbs. And here's kind of a big picture product of those feedback loops that I mentioned. And our last active protein digestion is our pancreatic proteases will hydrolyze the proteins into oligopeptides. Peptidases finish the job because they're attached to external surfaces of our intestinal cells, and they cleave oligopeptides into amino acids and di and tripeptides that can be transported into intestinal cells via transporters. And there are 7 types of transporters that are specific for some amino acid groups. And then those amino acids are released into the bloodstream by antiporters for use within the body. Here's a practice question. A 43-year-old overweight woman presents to her doctor's office because of right upper quadrant abdominal pain. She's experienced similar episodes of this type of pain in the past and admits that it's worse after meals. Increased secretion of which of the following is responsible for her pain? Is it cholecystokinin, decreasing the secretion of gastrin, pepsin, somatostatin, or vasointestinal peptide? It is cholecystokinin. The classic presentation of this is cholelithiasis or gallstones, and patients with cholelithiasis experience pain after meals as a result of the duodenal release of cholecystokinin. This causes the gallbladder to contract, while the stone obstructs the cystic duct. Cholecystokinin is stimulated by fatty acids and amino acids. And then I kind of have the other answer choices, why they're not right. Gastrin's released by our G cells in response to proteins or peptides in the stomach. Pepsin is released by chief cells in the stomach. Somatostatin is released by D cells in the duodenum, and vasoactive intestinal peptide induces smooth muscle relaxation. That's all we have time for right now. When we come back, we'll talk more about our gastrointestinal system.